I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about PCOS and menopause and what happens if you have PCOS and are going through menopause. So before I get into the first thing I want to make very clear is that I'm not giving any type of medical advice. So if you have any questions about your health, make sure you go see your healthcare provider. And of course, as always, I am not giving any advice on religion. So if you have any questions about your religion, make sure you go see a friendly neighborhood religious leader. This is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So you all know this wonderful doctor. She's been on twice before, and I do my retreats with her, and I love Basma. But for those individuals that may not know who you are, Basma, if you could just introduce yourself.
Yeah. Hi, everybody. I'm Dr. Basma Faris. I'm an OBGYN, much like Dr. Sadaf. And we are, again, we co-host a retreat together. But when I'm not in Morocco, I am I'm a practicing OBGYN. I have a telemedicine practice that focuses on PCOS. I have a background in nutrition, and I'm a certified culinary medicine specialist. And so today we're going to talk a little bit sort of about where our expertise sort of overlies each other. What a great topic.
Yeah, and Basma's amazing. So, all right, Dr. Faris. So, if you could briefly define PCOS for those individuals that are like, "Hey, I think I may have it. I'm not really sure," but using the most current diagnostic criteria, where we are now versus how PCOS was seen historically in the past.
Yeah. So that's an excellent question. PCOS is a hormonal condition, an endocrine condition that affects multiple different systems in the body, including our reproductive system, but also our metabolic systems. And really, it impacts every single organ system. And basically, people with PCOS struggle with a cluster of different symptoms, but there are some, similarities or themes that run throughout. So when we diagnose people with PCOS, we're looking for the following criteria. We're looking for people who may have irregular menstrual cycles, or maybe they don't have a period at all for several months. And so irregular meaning, the length of the menstrual cycle, so the beginning of one period to the beginning of the next, may be longer than average, or really varies from month to month. And so that really is a signal of some dysfunction in the ovary. We are also looking at signs or symptoms of having elevated androgens. Androgens are hormones that, they used to call them male hormones, but we know that females and people who were people with ovaries produce androgens as well, both from the ovaries and from the adrenal glands. So we may find that those levels are elevated on blood test, or people may have symptoms consistent with that, which may be things like facial hair or chest hair or balding or cystic acne. And those would be symptoms of having elevated androgens. And then lastly, as sort of the name implies, there is this characteristic appearance of the ovary on ultrasound called polycystic ovarian morphology. And they're not really large cysts per se. It's when there are lots of these little tiny cysts, which are just the follicles that house our eggs. When somebody has more of them than they're supposed to, that's what we call polycystic ovarian morphology. And so to diagnose somebody, they need to have 2 out of those 3 criteria, and that also we have to exclude other causes. So we have to make sure that there's not another hormonal disorder that could be mimicking the same symptoms. Yeah. Historically, we really thought of it just as a reproductive disorder, right? That caused irregular periods and that caused, potentially infertility. And now we really understand that the whatever sort of signaling defects that occur in the ovary are also occurring in many different organs in the body. So it really affects people from head to toe, from the skin on the top of the head to the brain. People with PCOS are more likely to have anxiety and depression, to things like sleep apnea. People with PCOS are more likely to have sleep apnea, more likely to have cardiovascular disease, and so more likely to have obesity. So to develop obesity, difficulty with maintaining their weight, increases in what we call visceral fat, which is fat around the middle or fat around the organs, increased risk of what we call MAFLD or metabolic associated fatty liver disease. So these are, every single organ system we can think about can be affected. And so what's important to note is that we used to think that, when you go into menopause, you don't have to worry about PCOS anymore. Or even when you get into your later reproductive years, you don't have to worry about PCOS anymore. But now we really know that that's not true. And there's more data that is coming out that sort of demonstrates the differences that people with PCOS experience as they get into their late reproductive years and into menopause.
Wow, that was amazing. Tell me, I I don't know if you mentioned AMH levels. Did you already
Yes.
talk about that? Yeah.
I didn't. So that is actually new to the diagnostic criteria for PCOS in
Maybe you
that
could explain just what that
so yeah,
AMH
so
stands for.
AMH is anti-Mullerian hormone. It is a hormone that is produced by the early follicles of the ovary. So when somebody has a lot of these follicles, their AMH level will be higher. And so now it has been added to the diagnostic criteria in that instead of having an ultrasound showing this sort of characteristic appearance of the ovaries, you could just have an AMH level. And if that's elevated, that will allow you to diagnose that one particular criteria.
Hmm. Nice. So, one of the questions that I wonder about, and I'm sure a lot of people do, is that why do so many patients with PCOS just not get diagnosed until years after, they've been suffering or until they start to try to conceive?
Right. So, this is really unfortunate, and we've seen this. We've seen this in studies that have been conducted in the United States and around the country. That there is a delay in diagnosis. It's in part due to, because you need to find these three different criteria. It can take time to diagnose people.
Yeah.
Some clinicians maybe aren't up to date on the diagnostic criteria. And historically, I think what added to the confusion were there were a few different organizations that had slightly different criteria. And so, with the most recent guidelines, the international guidelines that were published in 2023, it sort of reaffirms that we all should be using the same criteria. But people maybe that were, trained some time ago, or were using a different criteria, I think that leads to some confusion as well. And then there's just, unfortunately, what used to happen, and probably still happens in some places, was that if people were complaining of some of these complaints, like having irregular periods or heavy periods, maybe they were just told to go on hormonal contraception. And when somebody's on combined hormonal contraception, then you can't diagnose it, right? People need to be off contraception to have the diagnosis made, and then it's just sort of not really at front of mind anymore. And so it may not be until they decide to go off the pill or whatever contraceptive form they're using and try to get pregnant that they discover that they have this problem. And they probably had it all along, it just wasn't identified, or maybe their doctor identified it but didn't explain it to them.
Yeah. Yeah. And I think you're absolutely right. And I think that, sometimes that there's a bias as well. I'm sure you probably know that too, right? Like somebody that may be struggling with their weight and they come up with irregular periods, and you're just like, well, it's because you're overweight. And, this must be the reason why you're not ovulating or you're not getting a period. And, I'm sure you probably have PCOS. So they just put them on birth control without even really talking to them
Yep.
about what they're thinking or a diagnosis or anything like that.
Yeah.
Yeah. So I'd love to know, and let's just get into the topic. So, what do you think about, does PCOS go away? And I think you mentioned this a little bit at menopause, or does it just simply evolve metabolically and hormonally?
So what I was saying is that people with PCOS, as they get into their later reproductive years, because the number of eggs decreases as it does for all of us, then people who maybe previously had irregular periods start to have a normalization of their menstrual cycle. So we see
Mm.
this often in people with PCOS. They were irregular in their 20s, they were irregular in their 30s, and maybe towards their late 30s, early 40s. Now, finally, they start to have regular spontaneous ovulation and regular spontaneous periods. So they think their PCOS has sort of gone away. And so what's actually happening is their AMH is coming down to a more normal level. It's still higher than their peers who don't have PCOS, but it's in a more functionally normal level. And so people think, oh, my PCOS is gone, right? It's not really a problem anymore. And so, but the things that are occurring in the rest of the body, like many people with PCOS have insulin resistance. In fact, the majority have insulin resistance. And it's in this time that many people actually start to develop some of the metabolic complications of PCOS, like type 2 diabetes. And so we don't want to ignore this just because now all of a sudden the periods are regular.
Mm. That's so interesting. So, is it so? What I understood or what I thought was that because they weren't women or individuals with ovaries that have PCOS, because they weren't ovulating every month, that they had more eggs. So then they undergo menopause later in life. Is
Well,
that
that is
correct?
true as well. People with PCOS start out their reproductive years with more eggs.
Yeah.
There is some, theories that people have PCOS because they have less loss in their childhood years, so they're starting off their reproductive life with more eggs, and that certainly may be true. And on average, people with PCOS do go through menopause a little bit later, but usually by a handful of years compared to people without PCOS.
Yeah. Interesting. So what changes, and now correct me if you've already talked about it, but what changes with PCOS after the reproductive fertility years? So I think you mentioned that a little bit with the metabolic syndrome, right? That they start to develop more of the metabolic syndrome. And I feel like that happens for a lot of individuals, right? As we start to lose our estrogen, a lot of individuals will start to develop diabetes or high blood pressure or high cholesterol. Is that any different for women that have PCOS?
Yeah, it is. People with PCOS are at higher risk of those conditions than those without.
Okay.
And it seems that the most riskiest time for people with PCOS really are the perimenopausal years.
Mm,
And there is a marked increase in the develop of the metabolic implications. So much higher risk of type 2 diabetes, much higher risk of cardiovascular incidents. So, we're
mm,
talking about heart attacks and strokes and the
no,
like that normally you shouldn't see in somebody in your 40s. But
right.
what's interesting is that this time is really sort of a riskier time, the time leading up to menopause, and that when we look at people with PCOS compared to those without, even though we know that people in perimenopause, they're increased risk of all of those things, right? But they're
Yeah.
actually even higher for people with PCOS. What is
Mm,
interesting, though, is that after menopause, the people without PCOS actually catch up. But during that perimenopausal time period, those risks are increased. So, in people with PCOS, you don't want to think, oh, yeah, now they don't have PCOS anymore. I don't need to be as worried about their risk of diabetes, their risk of hypertension, the risk of heart disease. You actually want to be, even sort of more alert.
yeah. So, what does the evidence say about hormone therapy for women with PCOS in perimenopause and menopause?
So it's not hugely different compared
Yeah.
to people without PCOS. But what
Yeah.
is interesting is that people with PCOS tend to have um, fewer vasomotor symptoms
Hmm.
than those without PCOS, and so their need for estrogen may be not the same, maybe lower, and but certainly progesterone is still needed because people with PCOS often needed supplemental progesterone sort of throughout their reproductive life, because they don't ovulate as frequently, and tends to people with PCOS tend to continue to have higher androgen levels even
Mm.
after menopause. So
Yeah.
androgen or testosterone replacement is really less likely to be needed.
Mm. So interesting. Um, we talked a little bit about insulin resistance and metabolic health. So you were saying that, individuals with PCOS were at a higher baseline risk for insulin resistance and type 2 diabetes. And it's, is it called non-acute fatty liver disease?
Now the term is metabolic associated. It used to be non-alcoholic fatty liver disease,
Okay.
NAFLD. Now the preferred term is metabolic associated fatty liver disease, or MAFLD.
Hmm. And metabolic syndrome. So what does that mean for a woman? And so I think you mentioned this a little bit, right? Just to be more alert for individuals that were 45 plus and that had PCOS as they go through the menopause transition. So how would you counsel them? Would you counsel them any differently, or would you, focus more on like nutrition? I mean, there's a big push, and you're also a culinary medical professional, that would you focus a lot on the nutrition in this part of life, in terms of trying to prevent diabetes in individuals, just even in anyone, right, in menopause, whether they have PCOS
Yeah.
or they don't.
In anyone. But for people with PCOS, actually, this it's a pretty startling statistic that about 50% will have type 2 diabetes by age 40.
Wow,
So
50%.
50.
Wow,
So that
that's
is
a
a
lot.
pretty, if we don't do anything, right?
Okay.
And so that's a pretty staggering statistic. And that's much
Yeah.
higher than the
Right.
non-PCOS 40-year-old
Absolutely.
person. And so we definitely want to be extra vigilant and make sure that we're doing our screening in this population just even a little bit earlier. So yes, we all could benefit from better nutrition, making sure we get adequate fiber, making sure we get adequate protein, make sure that we're prioritizing our cardiovascular health, our bone health. But those with PCOS are, again, at slightly higher risk compared to those without. And so we want to really make sure that just because you're now regular, we don't stop being vigilant.
Hmm. So, what about cardiometabolic, or rather, cardiovascular risk screening? How would you screen for that? Is there anything that you would do different? Like, for example, for individuals that I have that are in perimenopause, menopause, that have a history of heart disease in their family, or even like a 50-year-old, right? I'll get
Yeah,
like a calcium score on them just to see where they are in terms of whether or not they have plaque before maybe starting hormones. I mean, you don't have to have that before starting
yeah.
hormones, but for some individuals, I do. I just check because they're interested. What about individuals with PCOS? Would you consider something like that? You
Yeah,
had
you'd wanna
talked a little
but
bit
you'd wanna
about.
consider it earlier, right? You wanna make sure that
Mm,
you are getting people's lipids annually, right?
yeah,
That they're having their blood pressure checked, that they're having their lipids checked on a earlier basis. So if we're talking out, we're talking about really sort of pushing that time frame up, I think, by about 10 years,
wow,
because they have already the elevated androgens, and whereas people, and both people with PCOS and people without are going to lose estrogen production to a degree. But what ends up happening after menopause in people without PCOS, even though people lose estrogen and testosterone, really end up being sort of a little bit positive on the androgen side, right? Just relative to estrogens. And so that loss of estrogen is what confers that increased cardiometabolic risk. People with PCOS are having that earlier, they're having that already. And so we don't want to wait till 50. We want to be really screening earlier. If people have PCOS, they should be having annual lipids checked, annual blood pressure checked, because we don't want to wait until now they already have type 2 diabetes.
hmm, got it. So, a lot of patients with PCOS say that weight feels impossible after 40. And I will say that one of the most distressing things that I see in my patient population, right, during perimenopause and menopause, and I'm sure you hear this as well, is that, the weight gain just comes on so quickly and
Yeah.
it's so difficult to take it off. Is there any difference in people with PCOS?
Well, people with PCOS are experiencing this even earlier,
Yeah.
right? They're experiencing this from oftentimes their 20s, their 30s, where all of a sudden really they're having a difficult time. And that has to do with, a few different factors. Because they have elevated androgens, they're accumulating more visceral fat, right? Which is something
Mm,
that people in perimenopause complain of. All of a
yeah.
sudden now, where they didn't have abdominal fat, they have abdominal fat. People with
Yep.
PCOS have that even earlier. People with PCOS have more challenges with appetite regulation. People with PCOS have, again, more, difficulty with this visceral fat distribution, which then worsens insulin resistance. And so it's very interesting. There was a large study that followed people with PCOS. This was actually in Australia, not in the United States. It was somewhere in the tens of thousands of people that they followed across 19 years. And
Mm,
what they found is even when they controlled for food intake, for exercise, those with PCOS gained weight at a rate of about a quarter of a kilogram per year more than those without PCOS, even
wow.
if they had the same sort of level
Yeah.
of exercise and diet quality. And so it just really goes to show the challenge that people with
Yeah.
PCOS have, and this sort of thinking that it's really sort of their fault. It's because they gained weight that they developed PCOS is really backwards thinking, and it's not the way that we should be thinking. And then we also have to recognize that there are people with PCOS who don't have obesity, right? So we don't want to ignore them as well. And some of them
Correct.
still have profound insulin resistance, even if they don't have obesity.
Right. 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 And that's that lean PCOS, right? To those individuals that
Yeah.
are thinner but still have the PCOS. So, how do you address this clinically and nutritionally without shame, fear, or restriction, trauma, or diet cycling?
Right. So, I think we have to change what we define as being success,
Mm,
change what we define as being, the goal of treatment. So,
yes.
my approach with my patients really much is very patient centered. What are their goals? Right? What is it that they want to achieve? Because if I tell them that the path to their, better health is weight loss and that's what we have to do and this is how we're going to do it, that is not what works, right? We need to figure out what is most important for our patients and then figure out how we can help them to get there, acknowledging that they have a disease that is making this more challenging for them
Yeah.
is incredibly powerful, because oftentimes that's not the message that they have
Right.
received by family members, by their medical professionals. That's not what they've heard. And so acknowledging that this is a disease that has contributed to their sort of metabolic health challenges is really, really important.
Right.
And then again,
Yeah.
success can be in many different forms, right? It doesn't have to necessarily be the number on the scale. So we talk about non-scale victories or non-scale wins, right? Changes in people's behaviors should be sort of rewarded, even if it doesn't result in, like, pounds on the scale, for example. But if people feel better, if they have more energy, if it makes them move better, if they have better just sort of gastrointestinal function, if they have improvement in their mood, if they have improvement in their menstrual cycles, there's so many different goals that we can sort of look at when it comes to PCOS. That's not just simply what do they weigh.
Yeah, I think that there's so much shame, right? Especially when it comes to weight. I think that a lot of individuals have been shamed for so long that it becomes very difficult. So, when you talk about the non-weight wins, I'm sure that's so empowering, right, for so many people because they see that there's progress, even if it may not reflect that, like
Right.
the
And
scale.
nobody's going to be worse off for making better behavioral, like, habits, right?
Right.
If
Mhm.
somebody's going to be eating better in a way that's going to improve their long-term health, that's going to reduce their long-term health risks, that is a win,
Yeah,
whether they change their
absolutely.
weight or not. And so these are the sort of conversations that we need to have and the things that we need to emphasize. And so sometimes, I mean, I was in one of the many groups that I'm in was sort of reading a conversation that was being had about a patient's sort of refusal to make change, or patient's refusal to want to lose weight, and how frustrating that was for, for their OBGYN. And I get it. I get we're frustrated. It's not easy, but there are different ways of approaching that maybe really can still engage people, and not, and so you can really partner with people in a different way when you just sort of change the conversation a little bit.
Yeah, absolutely. So, this is something that's really interesting. Is what about GLP-1s and PCOS? What is the evidence for GLP-1s? I know they do a lot of great things, especially for heart health.
Yeah.
But is there any research or evidence in how it helps individuals with PCOS?
Yeah, some of the research is on some of the older GLP ones, which are not the ones that we are using today. But there have been a few studies that were published this year that do show that they're very, very helpful in terms of helping people who, previously had difficulty with weight reduction, and could potentially improve even the reproductive complications that people have. So, improving, ovulation rates and menstrual regularity. The challenges in people who desire pregnancy, and what is the appropriate timing for using them in people who still desire pregnancy? When should they be stopped, etc.? Are we causing more harm by having people sort of weight cycling prior to pregnancy and then pregnancy? And so there
Mm.
is still sort of a lot of debate around use in reproductive age women and people with ovaries. But if we're talking about people who are now, done childbearing, especially going into those more challenging perimenopausal years where you have PCOS and perimenopause layered on top of each other, sort of
Mhm.
two metabolic challenges, they can be really, really helpful. And many people, finally feel like they can breathe and just sort of feel relief that they finally can get a handle on their health by the use of the GLP-1 agonists, because it allows them to just better make the behavioral changes that they need to make.
Yeah. I guess another question that comes up is when would you use metformin versus GLP-1? But I think you already answered that, right? Like if an individual is trying to get pregnant, then metformin may be the medication that you put them on, which, oftentimes will help individuals with PCOS ovulate, which will help them to get pregnant and also help reduce the insulin resistance that they have.
Right.
Opposed to GLP-1 that you have to be careful of when somebody's on it if they get pregnant.
Yeah, so metformin certainly is a tool that we use, a medication that is used to treat the insulin resistance. Many people have great success with it, and it can help with modest weight loss. It's not going to result in the same amount of fat loss as the GLP-1 agonists. But again, if we're talking about somebody who is intending pregnancy very soon, that may be a more appropriate choice for them. It's also much, much, much less expensive and so much more accessible. But there are some studies using both, right? Showing that using them both together is better than either of them alone. And that makes sense because there are often multiple different sort of points where the signals are just not, being, transmitted optimally in somebody's body. And so using multiple different medications that have different sites of action can often have a synergistic or additive effect.
And to your point of what you just said, they've shown studies, and I'm sure you've seen those studies, right, where GLP-1s and menopausal hormonal therapy work really well together for individuals who are trying to lose weight, that menopausal weight gain that a lot of individuals get. But they've known that the GLP-1 along with the menopausal hormonal therapy has a lot of synergistic effects, and individuals tend to lose more weight when they
Yep.
use both.
Yep.
This is a question that I often get, and I'm sure you get it too, is are there any supplements that you would recommend in menopause that, will help? And I actually saw somebody's, like on Instagram, I saw somebody and they said, yes, the supplement I would recommend is vitamin H for hormones.
Right?
Is
Vitamin
that-
E for estrogen,
yeah,
right?
right.
Yeah, which is supplemental hormones, right?
Yeah.
There are different supplements. I will never say that there's really one blanket supplement that everybody should take, because everybody's nutrition supplements are supplemental,
Yeah.
right?
Yeah.
And yes, there are some supplements that can be used in a therapeutic way, but I never make blanket supplement recommendations.
Yeah. Yeah. Okay. Well, that's awesome because I don't either. And I am like, am I missing something? Do I not know? So I'm like, okay, there
No,
you have it. The culinary expert has said there's no supplements. Okay. Very
it's not that
good.
there's no supplements, it's that there's no one supplement that all people should be taking, right?
Okay.
Everybody's health risk's different, everybody's nutrition is different. And so we
Yeah.
need to understand, what is it that you're missing? What do you need more of? And
Yeah.
we can't do that by just, and because to say that there aren't harms from supplementation would be, would not be honest.
Yeah.
And, so we have to acknowledge that as well.
So, I mean, but so I would say that the supplements that I do know that help, right, are magnesium in like menopause, and also I would say like calcium and vitamin D, right, for the
Yeah.
bones. I mean, those are ones that we say even in, definitely in the reproductive years as well, right? We know that's really important.
Yeah,
So
and most people but most people are deficient in vitamin D, right?
yeah,
So certainly
yeah,
if somebody was not deficient in vitamin D, they wouldn't really benefit from supplementation, because
yeah,
they have
well,
adequate
we have it, yeah,
amounts. And most people in their diet don't get enough calcium. So in that case, calcium would be beneficial for them because it's supplementing what's missing. And
right,
same with magnesium. Magnesium is helpful for many things: for sleep, for digestion, for insulin signaling. So there are many different uses, and there's different formulations. And so, but again, right, there can
yeah.
be, there certainly are certain circumstances where some people need some things, more than others.
You know something that I learned from you? Well, I learn from you all the time, but one of the things that I
Likewise.
remember that I learned from you on the retreat is when we were at the farm and we were having that cooking experience, and you were talking to one of the participants in the retreat, and you were talking about vitamin D deficiency. And this is a little bit off, topic for us because we're talking about
Yeah.
PCOS and menopause, but I think this is something that's really important that you brought up, the research in Mount Sinai and what they noted about individuals that had fibroids,
Yeah.
and they noted that all of those individuals were vitamin D deficient. I don't know if you can talk about that
Yeah, or
just a little
many.
bit.
I don't know if it was all of them, but certainly there have been multiple
Yeah,
studies that have demonstrated that people with fibroids are more likely to be vitamin D deficient, and that supplementing with vitamin D to replete or treat the deficiency can, potentially slow the growth of fibroids.
yeah,
So that is really, important. So if you know anybody who has fibroids, checking their vitamin D levels is a great idea. Most people in North America, to be honest, are deficient in vitamin D. We
yeah,
don't spend that much time outside. We're indoors all the time. And so that vitamin D supplementation, and it's not, uh, you know, people of color, Black women tend to have more fibroids. They also tend to be more vitamin D deficiency, or deficient, due to, melanin's sort of protective effects, but also may reduce the vitamin D production. So that's really a group, if you're caring for people with fibroids, that's something that you're going to want to address.
yeah.
And so that can be beneficial.
Yeah, and of course, like we always say on these podcasts, this is not meant to be any type of medical advice. So if you have fibroids, right, you just want to get that checked out. And if you have low vitamin D, then see if it helps. So, but I thought that was a really important point that I wanted to make sure that I brought up. So, we know that PCOS has a huge impact on mood, anxiety, body image, libido, and identity as a woman. How do you think we could support midlife patients who feel like they're just battling their bodies since the age of 15?
Yeah. I mean, we have to support them throughout. But what happens then in perimenopause and then after menopause, which is interesting, is that people with PCOS tend to have persistently high androgen levels. So even though their ovaries
Mm,
are no longer, they're no longer ovulating, um, those androgen levels remain elevated, sometimes even to the 70s or 80s.
wow.
And so that's, really what has been seen. And so people still may need anti-androgen therapy. They may still need progestin therapy because those androgens can be converted into estrogens and
Right.
contribute to thickening of the endometrial lining, which is a risk factor for endometrial cancer. And so we know people
Right.
with PCOS are at higher risk for endometrial cancer. And so, being aware of that is really important because that risk doesn't go away even after menopause. If anything, it probably increases. So knowing
Mhm.
that and supporting them in that way, acknowledging the fact that yes, they're still maybe might be struggling with, some of the facial hair, the acne, which they hoped, would improve with menopause and sometimes actually gets a little bit worse. And so, being able to support your patients and providing them with treatment options for those, for those complaints, right?
Yeah.
People want to feel their best, and we should help them. We should help them to do that.
Right. Right. So, we talked a little bit about that lean PCOS myth, right? Like if you're thin, you can't have PCOS. How should clinicians think about PCOS so they don't miss somebody that may be thinner but still
Right.
has PCOS?
So, anybody who presents with complaints of irregular periods or absent periods, that needs to be part of the differential diagnosis. So, you need to be thinking about that. It could be a different hormonal condition, right? It could be hypothalamic amenorrhea, it could be a thyroid disorder, but it could still be PCOS. And
Yeah.
so, honing in a diagnosis is really important for people because they have different treatment approaches. And so just because somebody is not, doesn't have obesity, does not mean that they can't have PCOS. And
Mhm.
I'd even go one step further. And this is sort of not really on topic for today, but people with PCOS can still at times have hypothalamic amenorrhea. And
Mm.
so, depending sometimes, and I've seen this a few times where people with PCOS but didn't have obesity were sort of using the same approaches as somebody who does have obesity, and maybe they were being overly restrictive with their food intake,
Ah,
and they
yeah.
go from sort of more of a PCOS picture to a hypothalamic amenorrhea picture because they're under consuming
Mm.
calories or they're under consuming carbohydrates or they're doing
Right.
prolonged fasts. And so it's difficult. It sort of muddies the picture, makes it a little bit harder to diagnose. But they can both occur in the same person.
That is such a great point, Basma. Thank you for bringing that up. Yeah, that's very good. So, what is one thing you want women in midlife, so midlife women with PCOS, listening right now to finally understand about their body going into menopause?
Yes. So you may get some relief of some of your PCOS symptoms, which is wonderful, right? You may start to have more regular periods, and that may help you just feel better, right? In just in many different ways, because now you're not sort of always wondering where your period is and having sort of prolonged, just different sorts of mood swings. You have a more predictable pattern, so that's great. That's fantastic. Having PCOS may actually be a superpower in you perimenopause and menopause. We've talked a lot about sort of what are the negative sort of things that may occur, but actually people with PCOS again may have less vasomotor symptoms than people without PCOS. So that may be actually like a great thing for you.
Mhm.
You may not, struggle as much. And actually, this was just published, I think, about a month ago. The SWAN study, which I know I've heard you
Yep,
talk about on
yep,
this podcast. So, those of
absolutely.
you who are familiar, right, this is sort of this longitudinal look at women in America
Midlife. Yeah.
across midlife and across their menopausal
Yep,
transition.
yep.
They sort of did a sort of analysis comparing people in the study with PCOS and those without.
Oh,
And they
uh-huh.
actually found that the sleep disturbances that were higher in people with PCOS prior to menopause actually sort of stabilized after menopause, where people without PCOS had worsening sleep.
I wonder
So
why that is. It has
I'm
to do with
not
the
entirely
estrogen.
sure. Yeah.
Yeah.
So,
Yeah.
so your sleep disturbances, if you have PCOS and you have had sleep disturbances your whole life, they may
Yeah.
actually get a little bit better. So there are some potentially things to look forward to. People with PCOS potentially have higher bone density, so maybe less of a risk of osteoporosis. So that's why we don't want to lose sight of the fact that even though you may go through a period of regular menstrual cycles before you sort of get into that perimenopausal roller coaster we all go through, that doesn't mean that we forget about your history of PCOS. Okay, because
Yeah.
some things may be better, some things might be a little bit more challenging. And so it's important to remember your history.
Amazing. And so, what is one clinical shift you want clinicians to start implementing tomorrow after having listened to this podcast and listening to you about PCOS and menopause?
Yeah. So assess your patients with PCOS, even like I said, even if they're not interested in childbearing, assess their metabolic health. Check a hemoglobin A1C, check a fasting insulin, right? Calculate their HOMA IR to see if they are having significant insulin resistance, because that's going to really help them. Check their lipids every year, right? Like people, when they're otherwise healthy, maybe going just to their OBGYN as their doctor, right? Because why go to two different doctors? And so
Right.
if your OBGYN can also do some of your primary care, we all only have so much time in our lives and have so many, dollars to spend on healthcare. And so if somebody's just seeing you as their main doctor, then like check their lipids, right? Check their liver function, make sure that they don't have, metabolic associated fatty liver disease, all of these things. Just because they no longer sort of are having menstrual complaints doesn't mean that you want to forget about all of the metabolic aspects of PCOS.
So good. So, Basma, for people that are listening and watching and thinking, wow, she is amazing. How can I become her patient? I'm suffering right now with PCOS. How can I become her patient? How can I follow her? I just want to know everything she knows.
Yeah. Thanks. So I have a telemedicine practice in 12 states.
Oh my
So the
God.
tri-state area,
Amazing.
New York, New Jersey, Connecticut, Pennsylvania, sort of up and down the East Coast, California, Chicago,
Wow.
Michigan.
Oh my
So
God.
if you're in one of the states, you can, check my website, Dr. So
Oh,
DRBASMA FARIS, and you can find out all the states in which I am licensed and I can see you by telehealth. You can also follow me on social media. I post a lot of just free education. So
that's so good.
Instagram,
Hmm.
I have a brand new YouTube channel. So
Woohoo.
that allows me to post a little bit.
What's the name of your YouTube channel?
Same, Dr. Basma Faris. So
Okay. All right.
DRBASMA FARIS. Um, that just allows me to talk a little bit longer than on Instagram. So
Amazing.
if you really want to
Yes.
take a little bit of a deep dive
Go
and
down the
spend
rabbit hole. Yeah.
a little bit more time with me, you can find me on YouTube.
Phenomenal. I love it. And of course, our midlife
Spend
women's
time with
routine.
us. Spend a
That's
whole week
right.
with us in Morocco.
That's
Whether
right.
you're in perimenopause or menopause or beyond, or you want to come with your mom and you just want to learn about what's up next and in life. Come hang out with
Mhm.
us. Spend a week with us in Morocco. This is going to be our third Love and Nourish retreat.
Woo-hoo. Yes.
First
Yes.
two have been wildly successful, and
Mhm.
last year we sold out in January.
Yeah.
So, I
Yeah.
think we'll probably sort of be in a similar situation this year. The retreat is in
Yes.
September of 2026. So check us
Yeah.
out. Come hang out with us.
That's right. We already have 5 people registered. It's
Yep.
September 17th through the 24th next year, 2026. So if you want more of just us, like me and Basma, come hang
Unfiltered.
out with us. That's right. That's right. Right. And we have such an amazing time,
Yeah.
and it's so amazing.
The
Marco's amazing.
sisterhood, what's so, I'm just going to take
Yeah.
a moment to really I
Yes.
learn
Ah,
as much as I feel like I teach, right?
yeah.
You learn from other women. It doesn't have to always be this one directional learning where we, as the experts, are talking to you or talking down to you from above, right? We are all in it together. We learn from each other. We laugh. We're unfiltered. We're raw. We get it all out there. Nothing is sort of off the table in terms of
Yeah.
topics that we talk about. And it's so, so, so much fun. And you leave with, I think, friends for life. So,
Yes.
yeah.
And it's so hard to make friends, right? And later on in life, like
Yep.
as we get older. So this is one way, ladies, for you to create new bonds and make new friends. I mean, we're friends with the people that we went on a retreat with last year and friends with people that we went on this year. And most of the individuals, Basma and I just met during the retreat.
Yeah.
So it really is such a
It's so
phenomenal
special.
space. Yeah. Yeah, so amazing. So amazing. Well, thank you so, so much, Dr. Basma Faris. You know,
Thank
I
you.
love you and love having you on here. So it is just my pleasure. And well, I am done here and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you have any questions about your health, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.